All right. Good morning, good evening, good afternoon. This is Dr. Ford, Posterior Wisconsin, with EMS. I wanted to take the time and do this lecture virtually. This is a lecture that we presented at our EMS MedX presentation that we do yearly. This was the 2026 presentation. And in it, we talked about posterior circulation strokes. I did day one. Dr. Kennedy did day two. So we'll talk about posterior circulation strokes. We'll talk about some of the anatomy, clinical presentations, diagnoses, and the management of strokes that affect the posterior circulation. This is a topic that is both clinically critical, I should say, and frequently misunderstood. Posterior strokes are usually not dangerous because they're rare. They're more so routinely dismissed. We see a lot of patients that come in with vertigo, with dizziness, and a lot of times we have a hard time sussing out what that means and to decide which patient is critical and which patient is not. The reality of the fact is, I made mention that I did a CME lecture, I think it was about a year ago, and in it they said if you go into 90% of the patient's rooms who have vertigo, you will make the correct diagnosis by sending them home and saying that it's just vertigo and the symptoms will go away with some meclizine, perhaps some Epley maneuvers, things of that nature for peripheral vertigo, BPPV. However, it's that 10% that we miss, and it's that 10% that, to be frank with you, we can't miss because of some of the devastating results that can ensue if we miss it. And so we'll cover clinical recognition, we'll cover the HINTS examination, some imaging limitations and management, and everything that you need to feel confident the next time that a dizzy patient rolls through your door. Here's the reality of what we're seeing. So about 15 to 25% of ischemic strokes are these posterior infarcts. And so this is not something that we're seeing infrequently at this time. It's something that if we're not seeing it, if we're not catching it, it's seeing us because of how insidious it can be. In some cases, as we will talk about, the symptoms are not necessarily any deficits in speech or deficits in motor. It's more so deficits in sensation. And that's with or without visual changes too. And so because of that, you have a 2-time higher rate of misdiagnosis in these cases. We also see a higher mortality, and a lot of that has to do with the location of these strokes. Cerebellar infarcts, for instance, can herniate. So you can get some significant edema that develops after these strokes. You can have superior or inferior herniation that ensues. In addition, these are artery occlusions. About 80% of those, there's an 80% mortality for those strokes. That's that locked-in syndrome that you get. And so something that we definitely need to be facile in diagnosing, kind of given the high stakes, and it could also be something that you can easily miss. So one of the things that I talked about during this lecture when we gave it at MedX was how this was something that I personally saw in my own family. And so this is my oldest son, Odie, when he was 1. My father-in-law is on the right here. Mo, he essentially lives for this child, always wanted to be a grandfather. At that time, it was his only grandson. And it came time for his first birthday party, and we had everybody come up. We got the smash cake, because of course you got to get a smash cake when a 1-year-old is 1. And my family came up from Chicago. My wife's family came up. And we had a whole day. And so again, Mo had been talking about this birthday party for a while, what he was going to do, what he was going to wear, all the things that we were going to do for Odie at that time. And unfortunately, during the birthday party, everybody was participating except for Mo. He was lying on the couch the entire time. Now, initially, when he came in, he told us that he wanted to lie down. We thought that was a little bit odd. We kind of watched him for a little bit. He thought it was something that he ate because the symptoms were mostly he felt unsteady. He felt as though he was sick. He said that, he had been throwing up too and thought he had eaten something that was bad. It was fall, so he thought he could have come down with something as well. And so we told him, lie on the couch. We'll reassess you. We'll come back and check and see how you're doing. In the past, he had strokes as well. And so that was always something that was in the back of our mind. But again, it's 1-year-old birthday party, and so we'll say we'll come back. And so the party continued. We came back and checked on him. He said that his symptoms still were pretty bad. We recommended that we were right down the street from the hospital, one of our hospitals here at Ascension, and said we can definitely take you there. It's probably good to get checked out. But he wanted to not make a big deal about it. Again, birthday party was the most important. He said that he just wanted to go home. At the time they were living in Madison. My brother-in-law was able to drive him back home. But I told my brother-in-law before he left, I said, if this gets worse, definitely take him to the ER. This is something that we need to consider, a stroke or if there's something else going on. And so later that night, I got a call from my brother-in-law who said, Dad's not doing well. We ended up taking him to the ER. I'm sitting there right now at the ER. He had a CT of head, didn't show any signs of any bleeding, had labs looked completely fine. They gave him meclizine, they gave him Zofran, he got a little bit better. They ended up doing a CT angiogram, given his history of having infarcts before in the past. And they just saw evidence of old ischemia. They didn't see any new signs of any new occlusions or anything of that nature. It was about 2:00 in the morning at that time. And so he ended up again, getting all those therapies and stated that he felt better. At the end of it, he said that he felt comfortable with going home. He was able to ambulate, a little bit unsteady, but was able to ambulate. And so they sent him home with a very low bar to return if his symptoms should worsen. I got a call the next day from my brother-in-law again, who said he's at the point now he can't walk anymore. He's throwing up more. And I told him, we're getting in the car. We were living in Milwaukee at the time. I said, we're getting in the car. We'll come up and we'll meet you. And so we drove up to the ER. In that interim, he got an MRI. They ended up repeating some labs for him. By the time we got to the hospital to see him, he could barely stand up. I had to help him ambulate. And this was despite meclizine, despite Zofran. He was still vomiting. They gave him droperidol, still vomiting. And they ended up getting an MRI of brain. An MRI of brain showed, which was the eventual diagnosis, which was a vertebral artery occlusion. Now, this isn't his picture, but this is something similar. Unlike these anterior strokes that we typically will see, unless you are able to have that high suspicion, and unless you're able to do MRIs, these posterior strokes can be missed. They can present as just dizziness. A lot of times people will think it's just something that they ate, and that's exactly why they are so dangerous. And so a lot of us have seen similar strokes. A lot of us have discharged dizzy patients only to return as a confirmed stroke, or have seen patients return from other hospitals. And so we'll get into a little bit about what happened with my father-in-law, but I just wanted to put that out there. These strokes are very common. They are something that we have a very finite time to catch, and they can be missed easily. So why is it so hard? So we talked about some of the clinical aspects of it, but this large area of territory that you usually will see these infarctions usually lead to nonspecific symptoms or atypical presentations. So we'll talk about a condition, one of the occlusions that we'll discuss, where again, you won't have any motor deficits at all. It's more so sensory, right? So you can get like a Horner's presentation, and you can have decreased sensation in one side of your body. So all these things are very nonspecific. And again, unless you have it in the back of your mind, that's what's going on, you may miss it. There are imaging limitations. And so, as we all know, working at various hospitals throughout our system, that sometimes there is no MRI available, right? Or you may only have a CT available, or there may be a contrast shortage. So there's a lot of limitations that can inhibit the time frame that you will need to make this diagnosis. There are a lot of posterior stroke mimics, as we have discussed in the past, and so we will talk about some of the more common stroke mimics as we go forward. But I just wanted to put that out there, particularly vestibular disorders that can lead to dangerous delays in this diagnosis. So you don't have to be a neuroanatomist. Or you don't have to be a neurologist either in order to know this anatomy. You just need to know and understand enough of why symptoms cross sides, why consciousness is affected, why the posterior fossa is its own dangerous neighborhood. And so if we look, let me see if I have a pointer. Here we go. So if we look here, we can see the vasculature of the circle of Willis. And so essentially, if you're looking at the vertebral arteries coming off of the subclavian, again, this is the area where my father-in-law had his infarct. And this area is pretty dangerous. In a lot of cases, when we talk about chiropractic manipulation, and this is why neck trauma can damage it as well, we see the vertebral arteries which cross through the cervical transverse foramina. So this is why if you torque on the neck too much, you can cause some shear trauma of those vessels, end up with a dissection as well. They unite at the pontine medullary arteries here, and this is where the junction is formed to form the basilar artery essentially. And so this is that area where you will get that locked-in syndrome. If you've been practicing long enough or have been able to experience this type of stroke, It is one of the more devastating strokes. Patients are essentially locked into their body. They can't talk. They can't really move at all. And again, that mortality is around 80%. As we said before, some of the stroke symptoms can be just sensory. So we look at the posterior inferior cerebellar artery. You can get a lateral medullary or a Wellenberg syndrome where you just have that sensory aspect. The basilar artery essentially branches into the posterior and superior cerebellar arteries. You have the posterior communicating arteries, and then it goes anteriorly as well. One thing to know is because the brainstem nuclei are so tightly packed, even small infarcts, so very small infarcts can produce large territory deficits. And because the brainstem controls your consciousness, controls your breathing, controls swallowing, these strokes can be rapidly fatal. In these cases, especially in cases where patients come in obtunded, if they can't talk, it's one of the things you have to have on your radar because the mortality can be so high in these situations. There are many posterior stroke syndromes, and so I'll leave this up here for you to read, but we kind of mentioned Wallenberg syndrome, where we talk about that ipsilateral Horner syndrome, the ptosis, meiosis, and hydrosis. On one side, you can have same side facial sensory loss or ipsilateral sensory loss, but on the contralateral side, so the opposite side, you can have sensory loss as well of the body. Talked about basilar artery occlusion, which is that locked-in syndrome, mostly affecting the pons. The distal basilar artery is that midbrain thalamus, which is affected, and patients will come in altered. I've had patients who have come in like this. Most markedly, there was one patient that came in with concerns for potential, THC gummy ingestion. And so no one had seen this patient ingest THC gummies. There's just a neighbor that told EMS when they got there that the patient had told her that she bought some THC gummies. And so her report was THC overdose when she came in for assessment into the emergency department. When I saw her neural exam was off. Her hallucinations, she had hallucinations as well. She was combative at times, but then all of a sudden became silent. We ended up getting the CT angio for her, and we saw that she didn't have an occlusion, but she had in the distal basilar artery distribution a large hemorrhage, right? And so this was a situation where that could have been missed if we had anchored on THC gummy overdose. So always have your head on a swivel, always be looking out for that. There is also through the ACA distribution, the lateral pons, you can get a intranuclear ophthalmaloplasia where you have issues when you're looking medially. You cannot do so on the affected side. And then you have nystagmus when you're looking laterally. And so there is an image on the bottom of the screen demonstrating that. So one of the things that we talk about too is how some of the symptoms are distributed when we see this, right? And so we see vertigo, we see ataxia, motor weakness too. And we're seeing vertigo as being the more commonly frequent characteristic of posterior circulation stroke. And when we say that, we have to kind of tease out what that means, right? So the most common and probably the most hated chief complaint amongst a lot of ED providers is the symptom of dizziness, because it can mean anything, right? So does that mean that you're truly vertiginous, right? Do you have vertigo? Do you have issues with vertigo is usually split into three different components. Are you having visual effects? Are you having your inner ear affected as well, right? So that BPPV sense. Are you having that sensation of spinning? Is your proprioception off? So vision, proprioception, and your inner ear are the three components of vertigo. One of the three or all three have to be off in order to constitute as vertigo. But then you get into the other bucket of dizziness, which is essentially just equilibrium. Do you feel unsteady? Do you feel wobbly? Are you feeling lightheaded, right? Is this a pre-syncopal episode as well? So it's very key that we differentiate what dizziness is in order to kind of get to the main diagnosis and see where we need to go. There's characteristic of peripheral as well as central vertigo that we talk about. So this slide is a fundamental slide, and it's really good to know So feel free to pause it, feel free to screenshot it. But ultimately, we talk about the onset. Is it sudden? Is it something that is gradual? Usually, characteristics of both are present in peripheral versus central vertigo. Is this severe initially, but then decreases over time? Is this something that is elicited, right, based on head position, right? Usually in cases such as BPPV, worsens when you turn one way or the other, versus central vertigo, usually little change that worsens with head positioning, right? We also talk about, can the patient walk? Walking your patient can really, tease out a lot, right? So it can tell you which patients you need to be worried about and which patients you're not, because usually BPPV does not result in any true ataxia. Now, a patient may feel like they're unsteady initially, but if they're falling over themselves, if they can't walk, that's usually something that it's a central lesion that you have to assume until proven otherwise. If you talk about the HINTS examination, one of the things that we discussed, and we'll go over the HINTS examination a little bit more, a normal head impulse in the context of doing a HINTS examination is actually abnormal, right? So that's a central pathology. And so we'll go over the HINTS exam and the saccade that you're expecting to see in a normal HINTS exam, but you're expecting to see an abnormal saccade in the head impulse test itself. So it's tricky verbiage, but we'll talk about it. We see acute vestibular syndrome, spontaneous, episodic, and trigger episodes. Usually acute vestibular syndromes are things like labyrinthitis, things like stroke. So these are acute onsets that are continuous and present on presentation. We see spontaneous episodic episodes. These are things like TIAs, Meniere's syndrome, vestibular migraines. These last for minutes to hours and not triggered by any movement at all. And then we talk about those true triggered episodes. This is things like orthostasis, right? Things like benign positional paroxysmal vertigo or BPPV. These last seconds to minutes, and they can be triggered by movement typically. This is a slide more so underline the fact that a very small infarct can cause very devastating results. We see a small basilar artery infarct, as demonstrated here, can lead to a large area, a large swath of that nuclei that is affected. And so more so can show you how devastating these strokes can be. So what we have here is the HINTS examination. And until I was able to really watch videos like this, and this one in particular, I didn't really understand the components of it more so in practice. Just, you can read about it, but it's one thing to actually see it and actually see normal versus abnormal too. So this is a good one to see here.
Less likely. So the first thing to do is to see if they have any of the central features listed here. New significant headache or neck pain, focal weakness or paresthesias, any of the dangerous Ds, diplopia, dysarthria, dysmetria, dysphonia or dysphagia, vertical nystagmus at rest, or a new inability to walk unaided. Patients with vestibular neuritis shouldn't have any of these concerning symptoms. If they do, work them up for stroke or call a stroke code if they have obvious significant neurologic impairment beyond just being dizzy and having nystagmus. So if your patient does have constant dizziness and you can see horizontal nystagmus at rest and they don't have any of the central features, it's time for the HINTS exam. And there are two things that you can't see and two things that you must see in order to definitively diagnose your patient with a peripheral cause of vertigo, which is almost always vestibular neuritis. Again, only use HINTS if they have constant dizziness and nystagmus at rest. Oh, and the other thing, the patient can't have a new hearing loss as determined by the finger rub test. Just rub your fingers together outside their ears and make sure they don't have a new loss of hearing. That's the plus part of HINTS plus, and a new hearing loss could indicate an anterior inferior cerebellar artery infarct. Back to what you can't see and what you must see in order to make the diagnosis of vestibular neuritis. You can't see nystagmus that changes direction with gaze, as in this woman who has left horizontal nystagmus looking straight ahead, and it still beats left when she's looking to the left, but when she looks to the right, it beats to the right. You can't make the diagnosis of vestibular neuritis with nystagmus like that. And you can't see vertical or diagonal skew deviation as in this man, whose right eye goes up and the left eye goes down as they are alternately uncovered. And you must see nystagmus that doesn't change direction with gaze, as in this patient who has left horizontal nystagmus, which increases intensity when she looks to the left and decreases when she looks to the right, but it's still beating to the left. And you must see an abnormal head impulse test, that is a catch-up saccade, when the head is turned rapidly in the opposite direction of the nystagmus. So for the woman who has nystagmus beating to the left, when I turn her head rapidly towards the left, right here, there is no catch-up saccade, but when I turn her head rapidly to the right, there it is, right there. That's an abnormal head impulse test, and in slow motion as well. And lastly, for the plus part, they can't have a new hearing loss. And if you do all this and see all this and document all this, you can then safely send the patient home with the diagnosis of vestibular neuritis.
All right. So a couple points in that. So essentially the indication is the biggest thing. So you want to make sure that you're doing the HINTS examination on the right patient. So the dizziness has to be constant, has to be acute nystagmus at rest and no central symptoms. So we kind of talked about some of the dangerous central symptoms at the very beginning of this as well. The patient cannot have a hearing deficit as well. That's something else that really suggests that the patient has a central cause at that point in time. We can't see nystagmus that changes gaze, also suggests a central cause. Vertical or horizontal skew is also a central indication. When done well, when these HINTS examinations are done, to the extent and applied accurately, the sensitivity has been found to be about 83% for signs of any central stroke. Now, with that being said, the intended audience in these instances are usually neurologists, right? So 83% sensitivity for neurologists who are trained in vestibular disorders, right? The issue that we run into as emergency medicine providers, is doing it in the population that we're supposed to do it in, as we'll talk about in this study, out of Ottawa, and then B, making sure that we are doing it accurately, make sure that we are applying what is normal and what is abnormal. This is a study out of Ottawa, and what they found was out of about 2,300 patients in this case that met criteria for inclusion in the study to see how we were as emergency providers at performing the HINTS examination. We saw the majority of patients, so about 97% of patients did not meet the criteria to receive essentially the HINTS examination. And so in that case, can you really be confident in that diagnosis? Can you really say this patient has a low enough pre and post test probability that we can send this patient home safely and feel confident that we're sending the patient home safely and that they won't return with a central cause? And so it's one of these things not to deter people from doing the HINTS examination, but it's one of the things is to say, we're very facile. We're very accepting of doing it in these instances where we have signs of posterior circulatory issues or vertigo. But it's one of those things to say, you don't rest your hat on it too much if there are other things that look to be clinically off. In that case, imaging may be the best case. So speaking of imaging, what to order in these cases, right? And so what we see, I made the joke that there was a gentleman that I used to go to residency with. His name was Rusty. And whenever we would do our M cases or our case reviews, we would ask Rusty to say, hey, man, what should we do next in this case? And he'd say CT, labs, right? In emergency medicine, about 90% of any cases of vertigo or dizziness will get a CT scan. And that's not inherently wrong, right? As I said before, the patient that we saw that was the THC misdiagnosis ultimately had a hemorrhage, right? CTs are really good at picking up hemorrhages. So they're fast. They rule out hemorrhages. They identify large vessel occlusions. We know this because we do stroke alerts all day, every day, where we're able to see anterior infarcts, right? And we're able to do endovascular therapy via IR if we find an occlusion that meets that criteria. So we know that they're good in those instances of anterior circulatory strokes. The issue, and DJ Khaled, who is my go-to here, the issue is it has very poor sensitivity for this indication in particular. So for that posterior fossa ischemic stroke, we know that it's about a coin flip, right? So CT scans are not great at picking that up. Some of that has to do with the bony artifact that we see in the posterior fossa. And so that really degrades the imaging quality. And we also see that for the sensitivity for all cases of vertigo, so whether that be vestibular disorder, whether that be posterior stroke, whatever, is about 28%, right? And so that's not a very good sensitivity when you're trying to rule in or rule out a cause of this dizziness. And we know the sensitivity for CTA is even worse. And again, we talked about the bony artifactual degradation of that image. We see that the sensitivity for that CT angiogram is around 14%. So even worse than the sensitivity for your CT without contrast. So again, DJ Khaled, major key here is a normal CT does not rule out a posterior stroke. So that's really important to know. We talk about the concepts of pretest probability. So in a lot of things that we do in medicine in particular, as well as emergency medicine, we can't wait for data validated studies, in some cases for randomized controlled studies that are a gold standard to be performed before we treat a patient, right? We have to estimate the likelihood that a patient has a specific disease before we do a diagnostic test, because we don't want to have a high rate of false positives or false negatives in those instances in order to make a decision about the patient's treatment and to do what's best for the patient in front of us. We always want to base the pretest probability on the incidence or prevalence of a disease process within the population that we're looking at. And a lot of that's done by the history and physical examination. A lot of it's done by taking into consideration who is a good candidate for this test or for this imaging modality. For instance, we use pretest probability often in emergency medicine. The heart score is a good example of what we do. We see a low risk heart score, which is usually about 0 to 3, is what we consider in the United States as a low risk heart score. Europe does a different standard, but to the United States, that's what we use. We see that pretest probability is 0.9 to 1.7%. And that is saying that that patient is low risk. There's a 0.9 to 1.7% chance of major adverse cardiac events that it safely allows for discharge, right? If the patient has a moderate risk, so a score, again, in the U.S., that's above 4 plus, I should say. We know that risk for major adverse cardiac events rises to about 12 to 16%. Those are usually patients that we admit. And we usually do that because we want to get that pretest probability below 5%, right? So 5% chance that something could go wrong, or 5% chance that we're missing something, in order to say, we can sleep at night, the patient can safely go home. There is another video here that talks about testing where pretest probability is low and how that leads to false positives and what happens when we test when pretest probability is high. So
To heart attacks to cancer. Testing when pretest probability is low can lead to false positives. Testing when pretest probability is high can lead to missed cases or false negatives. However, if doctors combine the information gathered about disease prevalence, patient history, and physical exams to determine the pretest probability, they can make more informed decisions when ordering tests and interpreting
studies is what he was going to say. But it just emphasizes the fact that we want to be sure that we're ordering the right test for the right indication. And again, if that pretest probability is super high, you may not be doing a service to that patient by sending them home if we do not know what that can be. So, or we don't know, if the patient is going to have an adverse outcome. And so this is a emphasis on that point when we're considering CT scan. So we know that the CT scan is not shown to decrease the post-test or the pre-test probability of posterior strokes. And a lot of that has to do with the low sensitivity, right? And so again, it's like a coin flip if you're going to see something, if something is there. We know that, that post-test probability, so meaning what is your probability of likelihood of a disease process after you've completed that test. We know that post-test probability is above the 5% threshold for ED rule-out processes and therefore is unhelpful in ruling out that diagnosis. We know that MRIs in that case too are not, are the gold standard, I should say. But within the first 24 hours, surprisingly, a negative MRI, the post-test probability is still above that 5% threshold. It's about 6%, right? And we see this over and over in the literature. A lot of times what happens is it takes about 24 to 48 hours for the the full stroke process to identify itself on MRI. So I say that to say, even though we have a gold standard of an MRI, let's say perfect world, an MRI is available that night that you're working. If that patient in front of you still cannot walk, if they still are extremely symptomatic and they have a negative MRI or an equivocal MRI, this is a situation that I would get neurology involved. I would get the hospitalists involved with as well. A, for patient safety. If they can't walk, they can't walk, right? But B, this is something that a lot of the data now is suggesting that, if we're not doing any intravascular therapy, if we're not doing TNK in these cases, it's maybe somebody that's a candidate for a repeat MRI in 24 to 48 hours after their presentation to see if we can rule in or rule out a process at that time. So again, we talked about the availability of MRIs is a limitation, right? So if you look at this tongue-in-cheek image over here, the people are doubling up on patients in MRI to cut costs in half, right? And so, MRI can miss up to about 20% of acute posterior strokes. And so again, even in best case scenario, in the first 24 hours, we can see some of those that are being missed, and we see that MRI misses about 1 in 5 if it's obtained super early within 48 hours after symptom onset. So I say that to say, if your patient is still symptomatic, really advocate for your patients. Make sure that, at the very least, the hospitalist or the neurologist sees the patient to make a plan that is safe for them. A normal CT scan does not rule out a posterior stroke. We talked about that. We know that the HINTS examination, when used appropriately, plus your clinical suspicion, is greater than imaging alone. So if you feel something is wrong, if you feel as though that MRI maybe too early, definitely, step out for your patients, make sure that you're advocating for them in that moment. So now let's talk about treatments. We'll kind of bring this home. So there are different treatments for posterior stroke, just as in the anterior cases as well. We know immediately you want to do the stroke alert if you have a high enough suspicion, but again, just know some of these can be really insidious. And so if you do not have, the criteria that are being met for your typical anterior stroke, definitely consult your neurologist, go over it with them. Don't be afraid to call that stroke alert. You can always call it off. You're getting IV, you're getting labs, you're doing a stroke order set. You're going to check for an EKG. Because a lot of times, especially in our younger patients, we're seeing PFOs, right, that can be open. So small openings in the heart the patient has. Atrial fibrillation, you can throw a small clot through the circulation, can end up with clots within the cerebral perfusion circulation. I think Donald Glover was just diagnosed with something like that, had reported that he had a stroke because he had a patent foramen ovale. So it's definitely something that you want to get an EKG just to rule that out, hook them up to telemetry. We know that thrombolytics sometimes can be indicated, especially if you are at one of our more remote sites. A TNK may be the only thing that you have available to you, so definitely something that you want to discuss with neurology as well. TNK usually is NIH stroke scale guided, but again, just know that some of these cases may not be your true, high NIH stroke scale application because it is posterior, not anterior. Typically, we say, in the cases of consideration for TNK, I believe it was a study, I think it came out in 2024, where they looked at the data validation behind doing dual antiplatelet therapy versus TNK, and they saw that there were similar outcomes in those patients in terms of, their outcomes at 6 months, 12 months, et cetera, and deficits thereof. And they saw that those patients that received dual antiplatelet therapy, as well as patients that received TNK, if the NIH stroke scale was 5 or less, they had about the same outcomes. In these cases of posterior infarcts, their NIH stroke scale may not be greater than 5, but you may still want to consider TNK if your neurologist agrees with it and if you feel clinically on your own that this patient has a TNK-able posterior infarct. Blood pressure considerations when we talk about TNK, we got goals for TNK candidates. So essentially, if you're considering TNK, you want to reduce the blood pressure systolically below usually about 180 or 185. And those are pretty standardized in your order sets. The reason for that is more so because you want to reduce the risk of post-TNK hemorrhage associated with keeping the blood pressure high. So if you're considering TNK, you want to make sure that you stay within the parameters of reducing the blood pressure. If you're not considering TNK, you're doing permissive hypertension. And that's usually until it gets greater than 220 over 120. The reason for that is you want to maintain your cerebral perfusion pressure. And so you're providing the brain with enough blood in those situations in order to have a better outcome. And again, that's usually in consultation, depending on where the stroke is, either with your neurologist, neurointerventionalist. And in the cases of things like cerebellar strokes, you want to make sure that you're also consulting your neurosurgeon as well because of the risk associated with hemorrhage. Thrombectomy is a consideration in a lot of these cases too, especially in the cases of basilar artery occlusions. They have very high mortality, basilar artery occlusions in themselves, about 80%. And we'll discuss some of the symptoms and some of the signs. But if you're able to do this intervention, we know that patients have good outcomes. To be honest, it's pretty hard to get into the posterior circulation, but patients still have a chance, right? So if I had a basilar artery occlusion, I know that I would want that chance in order to have, functionality. Usually, a lot of times when we see providers reluctant to do neurointervention, it's because of the thought of futility, right? And so there's a higher rate of futility in recanalization than anterior circulation LVOs, but we know that thrombectomy is still indicated up until about 24 hours out. So if a patient, is 6 hours into their stroke process, you've diagnosed with a posterior circulation stroke, just know that there is no futility in the setting if you're still within 24 hours. And to be honest, some neurointerventionalists are going after it after that too. So definitely make sure that you're getting neurointervention involved. Know that there's still a shot clock, but there is still a chance, and make sure that you are considering that in where you're going to dispose the patient. Basilar artery occlusions, as we talked about, usually sudden presentation. You see quadriplegia, hemiplegia, that locked-in syndrome. Often you have patients with gaze deviation. Gaze deviation is something that is big. You want to make sure that you're looking out for any central causes, whether that be hemorrhage or LVO in any cases of gaze deviation. A lot of times patients will say they have a prodrome of dizziness, of diplopia, double vision. You want to make sure you're calling a stroke alert, calling the neurointervention department ASAP. Again, that EVT, that intravascular therapy is usually within 24 hours. TNK sometimes can be bridged, can be a bridge for that until you're able to do intervention. So you want to make sure that you're getting intervention involved to see which way they want to go in terms of giving TNK first. Pitfalls, again, misdiagnosis, drug overdoses, dysfunctional syndrome, a psychiatric syndrome, syndromes in the setting of portions of the basilar artery being affected, often overlooked in intubated patients. If you have a patient comes in obtunded, doesn't look like they're breathing well, apneic, you intubate them, you may overlook this diagnosis as well once you're trying to do that detective work to see what's going on. And again, just delayed imaging due to low suspicion. So you got to have this on your radar in order to consider it. And so if you have somebody who is young, who had neck pain, who has stroke symptoms, their vertebral artery occlusion until proven otherwise, right? We see sudden neck occipital pain, but again, neck pain plus stroke symptoms is dissection until proven otherwise. This is where your CTA of neck is key. You can confirm with MRI or MRA if there's any intramural hematomas. There are a lot of mimics still, right? And so we talked about BPPV. One of the things that I do want to mention in this case is BPPV. The HITS exam is usually not indicated in these cases where pure BPPV, right? So usually you're doing the Dix-Hallpike maneuver. We talk about Wernicke's encephalopathy. So for our patients who have alcohol abuse syndrome, chronic alcoholics, this may be a thiamine deficiency. You want to make sure you're giving thiamine empirically. You want to make sure that you're controlling for the blood pressure. In that case, if your MRI is negative, multiple sclerosis can also present in a young patient with multiple white matter lesions on their MRI. So disposition. So we talked about where these patients go. You want to make sure that if the patient is unable to walk, these patients do not go home. Basilar artery occlusions usually go to the ICU, and that is for the potential of badness. Again, 80% mortality in those situations. Cerebellar infarcts usually do not go home either. You want to monitor them for edema, for herniation risk. Oftentimes you want to get a neurosurgery involved because sometimes they need to do a cutout of the base of the skull in order to allow allow for that edema to occur without any significant herniation, uncal herniation or otherwise. The patients that you do want to consider for discharge are patients that have resolution of their symptoms. Maybe you gave them meclizine before their MRI. I commonly do that too. That way, you're not waiting for the MRI for hours and then giving them meclizine, waiting another couple hours and then seeing if they're doing okay. I usually will give meclizine at the same time I'm ordering that MRI. So hopefully by the time they're all done, if it's peripheral, then we got our answer and they're feeling better. Patients with negative CTA vasculature, when it's indicated for those cases of vertebral artery dissection, you want to make sure that patient can go home if everything is negative. If in concert with your clinical examination, assuming that everybody's going to do the HITS examination for the right patients at the right time, do it correctly, interpret it well. If it suggests that it's peripheral and everything else clinically looks good, they can go home. And one of the things that we talked about before is you never want to discharge ongoing symptoms, or if it's inconclusive, or if you're not that sure about your HITS examination. So to wrap it up, in the case of my father-in-law, this is a picture of him after that next day when we got that diagnosis of him having a vertebral artery occlusion. He was in one of two of the best places that he could be. So at that time, this was about 8 years ago, at that time in Madison, the provider who actually performed his endovascular treatment was the provider that trained Dr. Gibson, who works for us for neurointervention at Ascension. And in that case, at that point, there were only about 2 or 3 providers nationwide that would go after posterior occlusions. And so essentially he was able to get endovascular therapy. He was able to retrieve the occlusion, and now he's back to baseline. He's able to ambulate. He's able to walk around. No residual effects from it, fortunately. This is a picture of him and my now massive children who are crushing him now too. So he's happy, a happy granddad. He's able to walk around, do all the things with them as well. So we're very fortunate that he was able to get that. So key takeaways. So posterior strokes are frequently missed. So you got to maintain a high suspicion. You have to know that CT of head does not rule out posterior stroke. So if you still aren't feeling well about it, the patient is still symptomatic, and you want to move on to the MRI. If the MRI is inconclusive and they're still symptomatic, you want to make sure that you're considering at least bringing that patient in or discussing with neuro. Know that the HITS examination outperforms early MRI alone in skilled hands. Not to say that we're not skilled, but more so to say that's usually intended to be, vestibular, fellowship trained neurologists, right? And so if you're doing it, make sure that you're doing it correctly and make sure you're doing it in the appropriate setting. Basilar artery occlusions can be catastrophic. And so you want to make sure that you are able to do all the treatments that you are able to do in your institution if you have a basilar artery occlusion. So that's endovascular therapy, that window is within 24 hours. This can also be TNK. Also, ABCs of emergency medicine, make sure you're protecting that airway. Make sure that you're considering that could be a diagnosis as well. Cerebellar artery infarcts can herniate. So again, even sometimes neurosurgery needs to get involved for large infarcts. You also want to think about the additional causes, right? So think about vertebral artery dissection in a young person who's coming in with neck pain and stroke symptoms. That is the posterior infarct of the young person. So that being said, thanks for listening. Definitely reach out to me. Feel free to email me. Jerry has my email. And if you have any questions, and I'll see you on shift. Have a good day. Bye.